Hi, my name is Tori Heverly, and my project was on asthma. Who guessed it? In 2010, a survey was done that said about 25.7 million people in the United States had asthma. 18.7 million adults and 7.0 million children under the age of 17. That's 8.4% of the American population. Asthma affects everyone, black or white, adult or child, female or male. 300 million people in the world are estimated to have asthma, and that number is expected to grow by another 100 million by 2025. It costs the United States about $56 billion a year for the treatment of asthma, between doctor's visits, emergency room visits, specialty doctors, and medicine. Asthma is defined as a chronic inflammatory disorder of the airways. In susceptible individuals, this inflammation causes recurrent episodes of wheezing, breathlessness, tightness, chest tightness, and coughing, particularly at night or in the early morning. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible, either spontaneous or with treatment. Approximately 250,000 people die prematurely each year from asthma. Almost all of these deaths are avoidable. It is important to understand the pathophysiology and etiology of asthma, as well as the types, classification, and treatment options. The pathophysiology of asthma is largely related to the triad known as airway inflammation, airway hyperresponsiveness, and airway obstruction. Eosinophils play a big part in the airway inflammation in asthmatics. In those who have had fatal asthma attacks, greater numbers of eosinophils were found in the medium and larger airways compared with controls or those suffering from non-fatal asthma. Inflammation of the airway affects the underlying bronchial hyperresponsiveness, which makes the airway more susceptible to bronchospasm. According to respiratory care principles in practice, airway hyperresponsiveness is a mechanism in which the airways constrict too easily and frequently, an exaggerated bronchoconstrictor response to a wide variety of stimuli. There are many factors associated with this hyperresponsiveness, including exercise, allergens, and viral infections. Inflammation of the airway is directly proportional to the airway hyperresponsiveness, in that reducing the inflammation in the airway can reduce the hyperresponsiveness. Airway obstruction is also known as the limitation of airflow through the airways, and it is usually caused by IgE-mediated release of the inflammatory mediators into the airways. Airway obstruction may also be referred to as bronchoconstriction. At the beginning of an asthmatic episode, which is commonly called an asthma attack, airway obstruction primarily affects exhalation. The reduced ability to exhale results in air trapping and a progressive hyperinflation of the lungs. The air trapping causes vital capacity to decrease significantly, as well as an increase in airway resistance, and hyperinflation causes the work of breathing for the patient to increase. Failure to control the work of breathing inevitably leads to respiratory muscle fatigue and subsequent ventilatory failure. The etiology of asthma is not completely understood. While genetics do play an important role in the development of asthma, it is unclear as to why some members of the family develop asthma and others do not. It is apparent that there are many triggers that can provoke an asthma attack. The most common trigger is infection. Other triggers include exercise, pollen, dust, cold air, pharmacological agents, allergens, and air pollution. Allergens such as house dust mites, animal dander, and food additives are common triggers for many asthmatics. Air pollutants such as cigarette smoke, sulfur dioxide, and oxidants can trigger an asthma attack as well. Additionally, beta-adrenoreceptor antagonists and aspirin have been known to provoke asthma attacks. An allergic asthma exacerbation is one caused by a specific allergen. The allergen could be an indoor trigger like mold, animal dander, cockroach antigen, or dust mites, or it could be an outdoor allergen such as grass or tree pollen. In addition, it could be a food allergen such as dairy, shellfish, nuts, mushrooms, or preservatives. This kind of asthma attack has two phases. the acute phase and the inflammatory phase. During the acute phase, the allergen causes the mast cells in the hyperresponsive airway to degranulate and rupture. The breakdown of the mast cells causes mediators such as eosinophils and leukotrienes to be released. The mediators cause bronchoconstriction of the smooth airway muscle, edema, vasodilation, and increased secretion production. During the second phase, which is the inflammatory phase, inflammatory mediators are released into the airway. Hypersecretion and even more hyperreactive airways, as well as a change in mucociliary function. This second phase of an allergic asthma exacerbation is the primary reason why patients should be monitored for at least 4 to 8 hours following the initial evidence of exacerbation. Allergic asthma may also be referred to as extrinsic asthma. Another type of asthma is called intrinsic asthma, and this type revolves around viruses. Viral illness seasons, October through December and February through April, coincide with the most prevalent hospitalization periods for both asthma in children and adults. By the fourth day of a natural cold, neutrophilic lower airway inflammation occurs. This inflammation is more severe in asthmatics than in normal non-asthmatic patients. These phenotypes of asthma are nocturnal asthma, exercise-induced asthma, and occupational asthma. Nocturnal asthma is ubiquitous in 75% of asthma patients. It is defined in respiratory care principles and practice as a marker for uncontrolled or more severe asthma, decrease in lung function of patients who are sleeping. In other words, the presence of asthmatic symptoms at night indicates more severe, poorly controlled asthma. This decrease in lung function can be attributed to many factors, including changes in body temperature, vagal tone, mediators, inflammation, epinephrine, gastroesophageal reflux, sinusitis, increased mucus production, and/or sleep apnea. Nocturnal asthma should be taken very seriously, as it is a huge red flag for loss of control. Exercise asthma is present in 90% of asthmatics, and an estimated 11% of athletes have it. It is defined in respiratory care principles and practice as a form of asthma characterized by transient airway obstruction, typically occurring 5 to 15 minutes after strenuous exertion. This particular cause of exercise-induced asthma is unclear. Occupational asthma is essentially airway hyperresponsiveness related to the workplace. Patients experiencing increased symptoms while at work may note an improvement hours after they return home from work or feeling much better on weekends and vacations. The cause of occupational asthma is usually an agent called an isocyanate. Isocyanate is a broad term for many different chemicals in the workplace, and it could be something as simple and avoidable as cigarette smoke, or it could be formaldehyde, grain dust, or a number of other chemicals. Asthma can be classified by severity. Severity is defined as the intrinsic intensity of the disease process, wherein the patient's frequency and the intensity of symptoms is evaluated. There are 5 main classifications an asthmatic can fall under: intermittent, mild persistent, moderate persistent, severe persistent, and status asthmaticus. Intermittent is the least severe, and status asthmaticus is when no matter what they do, the treatments are refractory, they're not working, and usually people like that die, but they don't like to call it status asthmaticus anymore today a lot because everything about the exacerbation is the same except that the treatment is refractory. The primary goal of treating asthma is to prevent or control symptoms and reduce either, if not both, the frequency or severity of the symptoms. Diagnosed asthmatics are equipped with a fast-release medication to battle acute exacerbations and 1 or more long-term pharmacological treatments to prevent and control symptoms. The first line in treatment of asthma management is an anti-inflammatory medicine called an inhaled corticosteroid. Mast cell stabilizers and long-acting beta-2 agonists are used to control asthma long-term, and the mast cell stabilizers are just an alternative. The long-acting beta-2 agonists have been made controversial as of late. Methylxanthine, leukotriene modifiers, and immunodilators are all other alternatives for long-term treatment as well. And then corticosteroids are used a lot. Xolair, if they're not responding to the corticosteroids, they're definitely usually steroids. And anticholinergics are one of the fast relieving alternatives, but usually they use short-acting beta-2 agonists. And ipratropium is the main medication in the fast-acting category that is used in the treatment of asthma. And some patients suffer acute respiratory failure with airflow obstruction and need to be placed on non-invasive ventilation or even be intubated, which is the absolute last resort. I hope you enjoyed my presentation and found it to be informative. Thank you.